Good evening again. My name is Jenny King, and I just want to welcome everyone to our fourth Science Cafe. And on behalf of Corey Tovian and Dr. Mujeeb Basit, we are really glad you're online with us tonight. I see lots of names I recognize. I'd like to give a shout out to Dr. Jeff Dobro. He is on a call with me at the early hour of 7 a.m. tomorrow. And I told him about this last week and he signed up, so I'm really pleased. Every other Thursday, we are hosting these conversations where scientists are going to take us on deep dives into fun and different topics. Our format is casual and interactive. Our speakers are UT Southwestern faculty and occasionally invited special guests. Our topics include the science of sleep, turning on your immune system with immunotherapy, the science of concussions, and those are just a few in the near future. We're also going to do one on June 30th that is related to a study that we are about to launch on COVID prevalence in North Texas, and so stay tuned for that. We encourage you to visit our events page at events.utsouthwestern.edu to learn more about our future science cafes. And as you all know by now, I'm sure you're Zoom experts, so just please mute your speakers so that we can keep the audio clarity in good shape for everyone. And if you do have questions throughout the program, just use the chat feature. Corey is going to be our Q&A moderator, and we welcome and encourage your questions. And with that, I'd like to turn the forum over to our speaker, Dr. Mujeeb Basit. He is our assistant professor in the Department of Internal Medicine at UT Southwestern with a specialty in cardiology and a focus on risk optimization. He will be introducing himself, and I hope he'll tell you a little bit about his career path, and then he will get our cafe conversation started. Dr. Basit?
Thank you so much, Jenny. Can everybody see my slides? It's really an honor to be here, and thank you all for coming. It can be very difficult late at night to come to these sessions, and I'll try to keep them casual. And I want to welcome you to my kitchen. And before this all started, this is where we would have friends over and we would congregate and we'd hang out. So I thought this would be the appropriate place to have it. I have my, UT Southwestern mug ready to go with a little bit of tea. It's a little late for anything else. But, I really love the kitchen because it is still the bastion of math in most homes. We do recipes, we do ratios, we do all kinds of things to make it all work. And I promise you that the amount of math required for this talk will be the same amount of math that you would do in a regular kitchen from day to day. There'll be one slide with some complicated equations, but there will be no exams on it whatsoever. It's just there for your reference. So I was very fortunate that, I did my undergraduate education at Baylor. And while I was there, I stumbled into computer science as my major. And that worked out really well for me because after that, I came to UT Southwestern while my older brother, was studying medical school, and I worked for the Human Genome Project and then the Dallas Heart Study. And that then led to me to have an interest in medicine. I did medical school, then internal medicine training, and then cardiology training. My wife is very, very patient. And then I did clinical informatics training. So I'm a clinical informaticist at heart. And that's really the field where we use computers to optimize the work in medical care. I do a lot of machine learning to figure out, prediction on who is at risk for what diseases and how we can better help them control those diseases at large. And part of that is, related to COVID in this case. And I was asked to participate. This is not something that I've done personally. It requires a big team. And, Dr. Pearl, Danizer, Tomei, and Jameson and Michael Holcomb in particular have been very instrumental, along with Amy Hughes, who does geospatial work, Richard Medford, who's an ID doctor, as well as an assistant chief medical informatics officer, Samuel McDonald, who's an emergency medicine doctor, and then we have people who've been advising us along the way, and it has been a great interdisciplinary team. So I just want to get a little level set on COVID-19, but these principles that we're going to talk about today can be applied to any infectious disease. So it's not just COVID-19. The first case that we saw was in early December in Wuhan, and that slowly began to spread. The first US case was in mid-January, and then it really began to spread throughout the country. And this is a phenomenon that had always been theorized because we have really fast air travel these days. This is really a new thing. And COVID is the ideal disease to spread like this because you have an asymptomatic period or a very low symptomatic period, but you're still shedding virus. And we'll talk about testing later. Now we're at over, almost 7 million cases confirmed globally, and we're over 400,000 deaths globally that we know of. And I would consider these numbers to be the floor. They're probably much higher than that, but it's only if you test it will you know that it's actually there. So I just want to start out with a quick poll. How concerned are you with contracting COVID-19? Yeah, I think this is very reasonable, and this is what we're seeing at the national level. And it depends very much on what's the news cycle that's going on right now, what part of the country that you live in, and what your local effect has been from that. And right now, there's been increasing press about COVID-19 in the Dallas-Fort Worth area, and I could definitely see this response being totally reasonable. So I just want to say one thing about this. We're going to talk about a lot of statistics and a lot of numbers, but I just want everybody to keep in mind that, these are people. These are people who have been affected in their day-to-day lives, who's been impacted from the economic consequences around that, and have led to significant loss, either directly or to someone that they know. So I always think about it starting from the person's perspective and calculate the statistics accordingly. And we'll do that when we go through this session. So thinking about the individual, and if you think of time going from left to right, infectious diseases work in these categories. You start out being susceptible, meaning person who's never seen this virus before or has been vaccinated from it. You become exposed to someone who has it. You then potentially become infected. You may require hospitalization. You may require a stay in the intensive care unit. It may require ventilation to help you breathe. And then you eventually recover, and then you become resistant. And the science is still out on this, but we would hope this would be the course. Now, it's not so clear-cut. These aren't equal bars. What we see when we transition to one block to another is that only a certain percentage of people require hospitalization. So there's actually, we can calculate the probability for requiring hospitalization for an individual, and this is affected by all kinds of risk factors. Do you have underlying lung disease? Are you immunosuppressed? Are you particularly susceptible because of your genetics? And we don't know a lot of the answers to these questions, but this is something that we work through in terms of forecasting. We also care about how long do you require hospitalization, and there are a lot of factors that affect that. But we're able to get that data directly from leveraging the electronic health record because we track all of that data in detail, and we're working to build bigger and bigger collaborations to get more and more accurate data around this. So if you then think about what information is really important for these various states, you can see there's a lot that we look at. We look at, for susceptible population, we look at the census data to say how many people live in Dallas County and the DFW area. For the exposed data, we look at mobility, we look at the transmittability of the disease and how much interaction happens. For the infected cases, we look at incubation period. What are the infection risk and what are the length of the infection? Now, these first three elements are actually quite hard to calculate because they're so dependent on testing. If you don't test enough people, those numbers tend to be very inaccurate. The hospitalization numbers are very accurate. We can get those through the interrelationship that we have in the Dallas-Fort Worth area. We can get them through billing data. Each one has its own nuances in terms of delay in reporting and accuracy of the value. We look at ICU data and look at comorbidities and how those comorbidities relate to length of stay and how that may impact your staff resources. We look at ventilators. How long do you need those ventilators? The ventilators are the critical linchpin in this. If you use up all your ventilators and you need a ventilator, your likelihood of death approaches 100%. It's very, very important that the ventilators be available, and eventually people will get recovered, or they'll get tested and they'll self-isolate and remove themselves from the population, and unfortunately some people do die. So when we look at this as an individual disease, what we do is then we lay out this timeline of the disease. We say, here's someone who was susceptible, they got exposed, but they didn't contract the virus. So they go back to the susceptible group and they go on over time. Here's someone who got infected, stayed home, hopefully self-isolated, recovered, and went back to this new potentially resistant population. Here's someone who required the whole gambit. They got infected, required hospitalization, ICU, ventilation, eventually recovered, and went back to that group. And here's someone who may have gotten the disease and then died. So these lines are a way to think about the disease on an individual level. So how do we take this and how do we calculate all the statistics and all the different graphs that we see? So we built a cumulative curve. So if you take an individual person, lay it across the line, and from left to right is time, this is the first person that gets potentially infected in our community. We tend not to know about these people until someone gets hospitalized. So notice this first person was hospitalized. And like I told you, we don't usually know about exposed and infected because that's before they get a positive test. And that's usually an assumption that we have to make. So I'm particularly excited about this cross-sectional study that will be in a future Café, which will give us insight into that earlier group. So if you get selected for that study, I hope that you participate because it is really important. So as we add more and more people, you can see some people die, and then we get a nice curve that shows all of these people over time. Now we're looking at a large group. And from that, if you want to calculate a cumulative curve, well, guess what? We have the cumulative curve right here. This is the cumulative number of people who've had that infection over this time period. But we're not often interested just in the cumulative curve. We want to know how many people have the disease and are active at a particular time period. And for that, we do a slightly different analysis using the exact same data. We band the data, and all we have to do is look in this band and say, how many people have this curve during this banded period? And we get that curve. And we do that for all the other banded periods, and we get a curve that looks like this. Same data, just a slightly different way to look at it because it can help us decide what to do for various actions. The data that's particularly important to us is the hospitalization data. So I've filtered out all the data, and we're only looking at people who required hospitalization. And in this case, these are people who required everything up to ventilation. So from that, we can calculate how many active hospitalizations do we have. And here we have a really small number because remember the disease, they have to stay infected until the disease gets worse and then they become hospitalized and we start getting more and more hospitalizations. This number is really important because it helps us figure out where we are in the utilization spectrum of healthcare resources. But you might ask, well, we live in the United States. We have phenomenal healthcare resources. It's overrepresented and overfunded. Well, it's really important because this is really the crux of flattening that curve. We're flattening the curve so that it's below the healthcare capacity. And we may do a big flattening where we say, here's the stay at home, and we may have to do intermittent things along the way to maintain that curve below that level. And this is why it's really important. So if you look at the number of hospital beds per 1,000 people, we are not that great. Now, this is a little bit old data. This is from 2016, but it hasn't gone up much since then. If you look all the way on the left, Japan and Korea are sitting at about 7 beds for 1,000 people. We're sitting at 2.44. And at the time, this was actually lower than Italy. So keep that in mind. It's actually a pretty low number. So what you see here, I seem to have gotten some markings on here, and I don't know how to get them off. And then, so if you look at Texas, so Texas is sitting at 3 to 3.5. That Dallas area is sitting at 3 to 3.5. Texas as a whole is at about 2.9 beds per 1,000 inhabitants. And here's the scary part. There's 73 counties in Texas that have no acute care hospital beds. If you live in those counties, you're gonna have to travel a long way to get the care that you may need, and that could have a really significant impact on your outcome. And this is true not just for infectious diseases, but all diseases in general. So we look at past epidemics to try to figure out what happened by looking at excess deaths. And this is a nice measure of it to say, well, we don't know if someone died in the community, whether they have COVID, but in Dallas recently, we've started testing all our deaths in the community to see if they had COVID, which I think will really help us in our analysis. So this is the influenza in 1918, really, really terrible disease, significant excess deaths. And this is where we learned a lot of our lessons of social isolation really helps in these particular situations. There was this early peak that you saw, and the next year there was a really massive peak. And even in the third year, there was a significant peak. What's the difference here? Back here, we didn't have vaccinations. We didn't have all of the advanced medications that we had back then, and we didn't have an understanding of epidemic control and flattening the curve. So we can actually look at this data in our modern system. So this is the data maintained by the CDC. each vertical bar here represents a week, and they actually calculate using some pretty sophisticated statistics, this slightly orangish line that helps you understand what your expected number of deaths are. This is the flu season from 2018, this little bump right here. It was considered one of the most deadly flu seasons in the past decade. And you can see here, it's insignificant when you compare it to the impact that COVID had. COVID has had a huge impact on people who didn't put social restrictions or NPIs or non-pharmaceutical interventions in enough time. A lot of us benefited from the delay that happened in New York, and New York and Seattle were probably the canary in the coal mine that gave us that early warning and encouraged us to do that. And I'll show you some data later on that helps highlight that. So, this all comes back to testing, and we've heard a lot of questions on testing. So there are two types of tests. There's a viral PCR test, and there's a serology or an antibody test. The two antibodies that we normally test for are known as IgG, immunoglobulin G, and immunoglobulin M. Immunoglobulin M comes earlier, but doesn't stay around for very long, and IgG is the highly specialized version that comes in and helps you detect and fight infections. So the viral test lets you see if you're currently infected, and the IgG test tells you if you have a previous infection. So let's look at that and figure out what that helps us in our continuity. So the viral test is only positive when you have an active infection. So during the infected period, during the hospitalized period, during the ICU period, and potentially during the ventilated period. And other than that, when you start in the recovery period, that tends to fade away. And by the time you're resistant, it's not there anymore. So you won't be positive on that test. The serology test, on the other hand, works a little differently. Early on, it's negative, but later on it becomes positive, and it stays positive for a long time. So those of you who've gotten vaccinations and have required to demonstrate that you have serology resistance, that's what they're testing. Have you responded well to the vaccination? Did you build up enough of an antibody response to say that, yes, you're going to be resistant and you would not get that disease if you were exposed? Now, I will take this warning straight from the CDC that even though this test may be delayed and may show positive, we still don't have sufficient data to show that we will give you sufficient resistance. So I would not think that if I got a positive serology test is saying, hey, I have the IgG, that means I'm resistant to the disease. We don't know that yet. And there is a lot of complexity around how that response happens. So let's get a little bit into the modeling now that we've covered the baseline data. So there are three major types of models that we use, or forecasting algorithms. One is known as the SIR model. It is a type of a compartmental model or a state model where people fall into the susceptible state, the exposed state, that's a slightly more extended version, the infected state, and the recovered or removed state. And this is a well-tested model. It is an old model that's been around for a really long time. It can model a lot of scenarios. It does have some weaknesses because it depended on clinical assumptions. So the better your assumptions, the better the model. And it also assumes stochastic movement. Stochastic is a really fancy term for saying it usually uses random movement. And we're human beings. We don't move around randomly. We move around with purpose. So to model that purpose, it tends to be a little bit hard. So this is the most complex equations. I'm not even going to mention them, but for your reference, I've placed them in here. You go from susceptible to exposed to infected to recovered, exactly like we talked about on how to think about the disease. But in these buckets are large populations and not individuals. At UT Southwestern, this is exactly how we model risk in our EHR. So we look at people who were screened and have no known risk. They can transition to an intermediate risk, a low risk state. And then we have a, suspected for COVID test when we actually send them for the serology test. And as you can see here, here's the susceptible group, here's the exposed group, here's the infected group, and here's the recovered group. We model it exactly the same way. And our system tracks people's risk at an individual level so that we can better take care of our patients. So if you're really interested in playing around with these simulators and see how different parameters can affect it, well, there's some really good ones out there. Here's a good example of it. It has all these sliders that you can use and adjust them for how big the population is, length of stay, and so on to see what that effect is. It'll tell you what your buildup is like. It'll tell you how flat it is. It lets you tell you what interventions you can put on and how much your intervention will affect some of your statistics. And I encourage you to go around and play with it. It'll really help you understand how different NPIs and different interventions can affect the overall trend. The other type of model that we use is an agent-based model. And an agent-based model, each dot here represents an individual. It models how they move around, how they interact, what their chances of getting infected are. And then it can calculate these contagious evaluation statistics right here over time. You can see it's telling you what's your cumulative number, what's the current active cases. You can estimate economic impact from it. You know, it's a really well-established model. It's requires a lot of computational power when you start doing it in large populations. And then it also has some behavioral assumptions and characteristics that if you get them wrong, it can give you some wonky results. But with, implementing it well, you can get some really amazing results, and you can actually test scenarios that you can't test easily with other models. The last one is the curve fitting model. It's created all of these models are coming from the 1930s and 40s, so I don't want you to think this is any new math that we have created. This is just that we have the computational power and the data to analyze it better. This is a specialized logistic regression. It's very well established in ecology for, like fish farms and other type of farming mechanism use this to figure out when to do harvesting, for example. It's it's well proven in biological system, but it's very susceptible to the environment. It assumes a stable environment. And with these infectious diseases, we tend not to have that. NPIs are changing constantly. Human behavior is changing constantly. And that's what causes it to have some effect. But if you have those assumptions and if you have those scenarios, it works really, really well for that. So this is what's made COVID particularly interesting, is because it just came 3 years after this Data for Good initiative was established on the internet. And this has been phenomenal because it has made so much data that's usually behind really expensive firewalls available to scientists to better leverage it. And we're going to go through some of that now. So this is the Johns Hopkins data repository. They aggregate all the cases globally and bring it all together for a central data source so everybody can analyze it. It is free to anyone. If you want to go play around with the data, this is where you can get it. It has saved a lot of people and really encouraged modeling and advanced analytics for people. So I wanted to stop and take a poll. And for some reason, I keep getting little check lines on my slides, but they're minor. So the question is, how comfortable are you going out? Excellent. I think this is related to the earlier question about how worried are you about getting COVID. The distribution is slightly different, but very, very close. And this is absolutely true. Social distancing is the best thing that we can do to reduce it. And wearing a mask can help a lot as well, but it's not the same as maintaining appropriate distance. The mask that we wear in the hospital, the N95 mask, have a much better particular filter characteristics than regular masks, but regular masks still have a significant effect and it's better than nothing. If you look at Asian countries where the culture of wearing masks is there, their rate of spread has been significantly lower. So I want to show you how we model this behavior about going out. So through the Data for Good initiative, a lot of the big companies have released some of their social mobility data. So this is the most recent Apple data, the social mobility. And as you can see, walking and driving is almost back to the pre-COVID baseline. And here is Facebook data. It shows a similar effect. And here's Google data. And Google data is really nice because not only does it show it, but it breaks it down by specific type because they have access to their wonderful Google Maps. So you can see here's retail, recreation, grocery and pharmacy, parks, transit stations, workplace, residential. And you can see here, transit has not come back yet. But we take the Google data and we dive into it in greater detail. So this is looking at the Dallas counties, and Harris County is in here for a cross-reference. And you can see here when the early risk was deemed and the stay-at-home order, people did really well for a couple of weeks. and stayed at home and stayed distant, and our infections rate went way down. And as you can see here, but there's only so much that you can stay at home because people go a little kooky, and that slowly started to relax, especially when the case volume didn't come that people were expecting. And after the reopen order was placed, that trend has continued to go up. And as we will see with all this press going on, this is reflective in an increased case count because now we're increasing that reproductive number. So perfect transition into reproductive number. Reproductive number is a measure of the contagiousness of a particular disease. And here's an example. If one person infects 2 people a day, you can see how rapidly this disease can spread. So this is an R naught of 2. And you can see this represents 31 people that one person has infected. But if you're able to cut that in half, either with social distancing or hand hygiene or mask wearing, you can see that we can reduce that infection from 31 down to 5. And that's the importance of it. If you wanted to eradicate any infectious disease, take your pick, doesn't really matter, do a global stay at home for 2 weeks. These vectors can't sustain themselves without having a host. If you eradicate the host cycle, the vector goes away. And that's why vaccinations are really effective for controlling difficult to do diseases, because that vaccinated individual is resistant and therefore is not a viable host. So we track this reproductive number over time in all of the various counties. This is the latest data, and you can see that we're starting to see an upward trend in a lot of these. Now, I will caution you about looking at this little downward trend, because what we notice is there's a slight delay in reporting. So we always see this downward trend, but it's that data about 2 days prior to it that's the most important to look at. And we will continue to monitor this over time. So here's the hospitalization data, and being in DFW and having a very collegial medical community, especially on the informatics side, you can see we get really accurate hospitalization numbers, and you can see there's definitely an upward trend in Dallas County for hospitalizations. We have yet to see that in Tarrant County, but that may come later. And this is something that we're continuing to watch very, very carefully. So this is what our modeling does. So our forecasting figures out this trend and then says, where do we think this is gonna go? And we actually, this is our data that shows this is what we forecasted back in about mid-May, and this is the trend that we were expecting to see, and this is the actual trend that we ended up seeing. I think I'm getting this date wrong. It might have been a little bit earlier than that, but this is the trend that we actually did see. So we actually overestimated by a little bit, but within the error bars of what we thought that trend was going to happen in terms of number of infections. And we continue to do that on a bi-weekly basis, and that slide set is available publicly on the UT Southwestern website. So I know there's some pharmacists on this call, so I included a slide specifically about pharmaceutical interventions, because I feel like that doesn't get enough credit, and we always talk about non-pharmaceutical interventions. The reason for it is quite obvious. You can do non-pharmaceutical interventions immediately. Pharmaceutical interventions take a little bit of time to develop. So what we're looking at here is what would happen theoretically if you went from 15 days of an infection to 11 days of an infection. What it does is it significantly reduces your peak of infection. So we went from having almost 50,000 people to almost 42,000 at the peak. And this is assuming a population of about 7 million people with a pretty aggressive R sub T. And we didn't change anything else in the model except for this. So I'm really excited about some of the pharmaceutical studies that are coming out, which will help us flatten the curve. So what would have happened in Dallas if we hadn't changed anything? Well, you know, if you go back to the end of May, we would have been sitting at around 200,000 cases. Instead, we have only 9,700. So social distancing made a huge difference. If you look at the data, we are probably a week or two early in terms of putting in all of those restrictions. New York was probably 2 weeks late. I'd rather be a week early than rather being a week late, because once you cross that threshold, it is very, very difficult to recover. So I wanted to, I will skip by this slide. So this is so we also look at the data, case data, geopositionally. So this is Dallas County, and we're looking at the spread of the positive cases geospatially. So where are they in census block? And as you can see, it pretty much covered central Texas area and then spread out pretty fast. And you're seeing some effects here from different locations, travel patterns associated with spring break, and then the Mother's Day effect. And what you're seeing is as those active cases go away, that color goes away from the census block. And as the social distancing has been put in place, we've been able to flatten some of that curve associated with it, and these areas go back to being white. Now, as that social distancing reestablishes, it's going to come back to grow. Because remember, Dallas County can't say, we're going to stop the disease and we're going to close our borders and nobody from the outside can come in. You know, small countries can do that, but we don't have that ability, so we're always going to get some influx of positive cases. So I'm going to take a moment. Our last poll, what would need to change to make you feel comfortable returning to regular activities? And feel free to select more than one. Wow, this is really fascinating. And I 100% agree with everybody. Vaccinations are the key because it will stop the spread of disease. And being a healthcare worker, I'm required to get a flu vaccine, and it always makes me more comfortable during flu season. Proven treatment protocols, you know, if you look at the mortality rate that we're seeing in the Dallas-Fort Worth area with our excellent healthcare system, it's actually lower than the international average, and we're doing very well. Now, will that continue when our hospital systems get taxed? I don't think so. I think that'll be a totally different scenario, but I'm really optimistic about a vaccine coming out to help change how we think about the disease. So what's happened though globally is that as the social restrictions have been eased, there tends to be a hypermobilization. Everybody goes out, bigger lines in every location, and the disease tends to come back faster. We have not seen that effect as much in the US. What has happened is certain populations have definitely gone out, but if you look at the national polls, people continue to trend the same way that our poll trended, is that most people are like, I don't feel comfortable going out to restaurants, going out to bars, going, especially large events are really a big problem. And restaurants are trying very hard to socially distance by either blocking seats, reducing seat volume, and this trend is occurring throughout all of our marketplaces, not just restaurants. And I think people who figure out ways to innovate on this and will have to survive until the vaccine comes out will be very successful. So in terms of forecasting, it's important. We spend a lot of time and resources to make sure that we do it accurately so that we don't miss the curve and end up in a terrible situation. It's not any new math. It's been around for decades. We're just establishing it with richer and more real-time data. Understanding this data is critical, and understanding the streams through which this data comes is very important to getting accurate results, and it definitely has some nuances to it. So I wouldn't jump to conclusions when you see a lot of the data. So, but the NPI policies is what we track a lot of to say, have they been effective and what has been changing as we open back up? And that's been a really important thing. And I will say, as we get more and more data, forecasting becomes less and less important because it becomes more important to just monitor the data and look at the trends and then try to figure out where those trends are going in a shorter time period. And we've been able to do that. And I'll leave you with a great quote that came from Neil Ferguson, who's a PhD modeler for infectious disease. We're building simplified representations of reality. And models, unfortunately, are not crystal balls. They give us better insight than hunch, but they still have limitations. And we always have to think about what is the error bar associated with this model, not just what is the model saying. I want to thank a lot of people, you know, the Infectious Disease Division and Internal Medicine, the Lyda Hill Department and Bioinformatics, who've done a lot of the building, our great clinical informatics team, health system information resources, and the Enterprise Data Warehouse, who's been very supportive of our work. The DFW entire medical community, you know, Tarrant County and the Health and Human Services there, Dallas County and the Health and Human Services, and especially Dr. Phil Wong, who's been really a phenomenal leader in this, and Dr. Podolsky, who has really helped lead the mission at UT Southwestern to provide better guidance to the broader community, to the state, and nationally in terms of this. There are references at the end of the slides if anybody else is interested in some key assumption information, and I'm happy to take any questions that you may have.
Dr. Bassett, thank you. That was absolutely fantastic. I know we all learned a lot. I'm going to go ahead and start calling on people for questions. Once I call on you, please feel free to turn on your video and turn on your microphone so we can hear you. And again, if we do not have time to get to everybody's questions, we will be sending a follow-up tomorrow with the email. Please feel free to email in your questions, and we're happy to get them to Dr. Bassett to get back to you. So starting with questions, we had a question from Gina.
Hi, Gina Antica from the Dallas Morning News. That was a really great talk. I really appreciate you, clearly explaining the data analysis and the science behind it. One of the questions I had is, Dallas County is reporting the record number of COVID-19 hospitalizations. Do you think this is a sign that we're reaching the second peak?
I think the peaks will be a continual challenge. I think that you have to distinguish the peaks between the waves. I don't think we're having the second wave, but we're definitely having a slight increase. Now, we've only seen that data for about 3 days, and I tend to hesitate to jump to conclusion from those days, but it is something that we're monitoring very closely. And it might be the early sign of a wave. It might be an effect that we saw from Mother's Day. We also saw an increase about a week later. It could be a Memorial Day effect. It could be related to the protests, but the protests are probably a little too recent for that to happen. So if we had this talk 3 days from now, I could give you a better answer. But right now, we're definitely seeing a slight increase, and it's something we want to monitor to see where it goes very carefully.
Thank you.
Next, calling on Grace. Grace, you had a couple questions?
I think they're answered already by people making comments, but my question was, you talked, Dr. Bassett, about 3 different models, and I was just wondering which one the CDC uses, or if it uses all of them. Thank you.
That's a great question. And they use something that's called a model of models. So they mixed all 3 different kinds. I actually had a slide on it that I took out because of the complexity of it, but they use a mix of multiple models that include all 3 types. They're heavily weighted towards the SEIR models. The most of the ones that they use in an aggregated group are favored towards that because the SEIR is most flexible, easiest to do computationally, but they do have some agent-based models and prediction models that use a slightly more sophisticated machine learning algorithm to forecast. I feel like that's a weak answer, but that's actually what they do.
Dr. Bassett, it's definitely not a weak answer. And calling on now, Yeager had some questions.
Hi, Dr. Bassett. How are you?
Doing well. How are you doing? Great to see you.
Good. You too. What other data do we need, or at what point will we feel confident about if former infection provides immunity against future infection or reinfection?
That's a great question. I think it's going to be hard to assess until we get those people who've previously been infected into a clinical trial to see if that, and what we look at when we try to figure that out with vaccination is we look at their IgG titers to say, how much IgG are you producing? Because that determines whether you will be deemed resistant or not to the future infection. And we don't know what that threshold is yet. And what we also haven't seen for like wave 2 is we don't know if this virus is going to mutate and change its receptor just like flu does. This is why we have to get a flu vaccine every year. I'd love to get a flu vaccine like we do with, mumps or rubella or something that lasts you for 10 years, but it just mutates too fast. So it's too early to see what that's going to look like. But I think as we get subsequently more infections and as we track those, we'll be able to tell. So it's only a question of time that when we see more of those cases, we'll be able to give a more definitive answer.
Great question. Moving on, we have a question from Matthew, who actually has a couple questions for you. Matthew, if you wanted to go ahead and ask 1 or 2 of your questions. We'll give you another second, then we'll move on.
No, I'm not sure. Are you talking about my Matthew A?
Yes.
Okay, I do have a lot of questions.
Let's limit it to 2 if you don't mind.
Okay, I'm just so concerned about all this modeling, and from what I've gained information from, none of them are really accurate. And a modeling can only be correct, based on the data that are collected. how comprehensive, how detailed are the data collected based on demographic, information, social economic data, based on migration data, and things like that that can help. Things like that can help in regard to predicting accurately, because I know that this transmission is very dynamic. So how good are the data that has been collected, and how good are the old modeling resources accurate? Because I do not hear about the use of GIS, Geographic Information Systems, for spatial analysis. I did not hear anything about that. So how good is the modeling?
Let me show you. So we do GIS modeling, and we leverage data at every single level associated with it. And we look at all the things that you talk about. All models have an error. And the question you have to ask is, what is your error? And that's why I showed the slide that showed the error. Let me see if I can replay this while I answer the question. So we look at geospatial data, but the data that we have that's very accurate is the hospital-based data. The hospital-based data, you can't fudge it. You don't have to worry about collecting it. If someone gets hospitalized, we know they get hospitalized. And we know, since most people are getting tested for COVID when they go to the hospital, if they have COVID or not. What becomes a little bit harder in that case is, did they happen to have COVID and then went in for a delivery, for example, but they weren't really sick with COVID? So those are the type of nuances that we look at every single data element. By far, the hardest data to figure out is positivity. So positivity, meaning people who have the disease and you just happen to get a test from an outpatient clinic, is you're very limited to who actually goes and sees the doctor when they're sick, and who then does the doctor decide to give them a test. So for those things, we know that that's just the floor. That's just a starting point. And the real number is somewhere above that. And so we tend to start with hospitalizations and work in either direction, rather than starting with either the exposed data, which we have no idea about, or the infected data, which also is a floor level. So for each of those grains of data, it's different levels of accuracy. So you're absolutely right. When you assess these models that people are telling you, you always have to ask that question. What are you using in this equation? The thing that always concerns me is whenever people start quoting percentages. Percentages are particularly dangerous unless the data that they're based off of is very precise. People who say percent positive tests are really tough, because you have to actually know who's all that's getting tested. And that tends to be very inaccurate. So you're absolutely right. We get this data at all multiple levels. We get census block movement data as well through some of these resources. And we're working on including that in our models. We don't currently have it yet, but that's a pretty advanced modeling technique. But we're working on including some of that data to enhance the accuracy of our model. And this will be a work in progress for many months to go.
Okay, thank you very much.
Thank you, that was a great question. Calling on Joan next. Joan, you had a question for Dr. Bassett?
Yeah, I'd just like to make an observation and then a question, sort of suggestion. I was recently up in Canada, and in Alberta in particular, where they have been doing a phenomenal job in limiting the spread, the community spread, in part because the head of the Ministry of Health, whatever she's called, she's on the TV, the media every single day, giving an update on the number of cases, reiterating the importance of wearing a mask, reiterating the importance of getting tested, making sure people know where to go and get tested, making sure there are no problems associated with it. And it is every single day. And she speaks in a wonderful way. I mean, just go to Alberta Health and you'll figure out how to find for Calgary and Edmonton and so on. And the same in British Columbia, where they've managed to really keep the lid on the infections. And we are not doing that. We do not have people who come out and appeal to our sense of community and care for other people to say, this is why you need to wear a mask. It's I mean, just to keep saying it, to have posted at the entrance to every store that's open, are you wearing a mask? You know, whatever, so that people become used to it. We aren't doing that. And I'd like to know, I don't want to know anything, I'm not asking you a question, but maybe think about how we can get our leaders to do this for our own well-being. My suggestion beyond that really is that with all this modeling, and I know you're using the data that are most readily available, but you know, we've got outcomes of death, we've got outcomes of recovered, but we keep hearing in the news about people who are recovered, but you know, they can hardly walk across the room, they have to have somebody to help them with activities of daily living, their brain doesn't work anymore, etc.
Joan, I'm gonna I apologize. I'm gonna interrupt you for just 1 second. Do you have a question for Dr.
Yes,
Bassett?
my question is,
Thank you.
how can you incorporate that into your modeling? Because if people like Governor Abbott are looking at the availability of hospital resources and they're paying no attention to the terrible toll on the people who come through those hospitals, it's really not helping us a lot.
So I think they're all wonderful points, Joan, that there's been variability in how different countries have responded to it. And I'm looking forward to reading about it for many years to come and to analyze what was the most effective strategy. And I think it'll be interesting to see that data going forward. The effects that you talk about from severe illness are true of any illness. You go into the ICU, you get ventilated for weeks on end, you're gonna come out of it enormously weak. I'm gonna, call out one of my colleagues, a cardiovascular colleague, Dr. Ben Levine, who does research for NASA. And what they do is they take people and they lay them in bed and they tilt them up so their head is down a little bit, so they kind of experience zero gravity. And they test how long does it take for you to lose muscle mass. And it's shockingly fast.
Yeah.
What this disease is doing is it's destroying your lungs and it's also weakening your body. So, and you stay in the ICU, anybody who has to stay in the ICU and be intubated for 2 weeks is going to come out of it and have neurological deficit and muscle weakness and all of these long-term consequences from it. Mm-hmm. That's part of the reason why we say we have to be really cautious with this disease, because one of the things that I didn't mention is we don't know what the long-term consequences of having this disease is. What we do know is it has some heart effects. It has some other organ effects as well. We don't know. We may find out 20 years from now that there may have been something associated with this that we didn't know about. And it's a risk that we have to decide as a community to do. We don't do the economic impact modeling. That's not an area that we specialize in, but there are other people who do. And there's some really great literature out there on looking at that.
But even if the modeling...
Joan, I'm so sorry. Okay. We're going to have to move on to the next person. I apologize, but please email us and we'll get your questions to Dr. Bassett and get your response.
Sure. Okay.
I'm so sorry. We just want to get to everybody.
Understood.
So we are going to move on to Rudy Rodriguez. Who's got a question? Let's see if Rudy's still on. All right, I'll come back to Rudy. So moving on to Jacob. Oh, yep, that was you, Rudy.
Yeah, audio back on. Okay, I think my question was answered, but you'd mentioned, being social distance to the point where the vector dies or the disease needs a host or the virus needs a host. And my question was a little naive on my part, but I was just wondering how come the flu, we have a flu season, and then when it's not flu season, the next year we have the flu again. And then somebody responded in the chat that influenza is actually a year-round illness. I didn't realize that.
Yeah, it is. It's just the rate of infection becomes later. In the wintertime, we're more congested. The spread is a little bit faster for the flu because it's weather dependent in terms of how long it can survive on surfaces. So we do tend to see flu year long, and it just goes north hemisphere, southern hemisphere. The other thing to keep in mind is the reason why flu vaccines are particularly challenging is because, the vaccine developers have to figure out what strains of the flu are going to come to the US. If they get lucky and they pick the right strains, the flu vaccine is very effective. If they get unlucky and don't pick the right strains, the flu vaccine is very ineffective. For COVID, it's a little bit different. We don't have to anticipate we already know what strain is already circulating, And because of that, I'm optimistic that the vaccine will be more effective than we have typically seen for the flu.
Okay, thank you.
Great question. Moving on to Rebecca. Rebecca, you had some questions?
Yes, I just had a question about the antibody tests that are starting to come out. I'm a pre-PA college student, so our school is trying to open up back in the fall, but I just have some concerns over, you know, how effective would it be to get one of those antibody tests before I go back on campus?
Yeah, no, that's a great question. And, you know, like I said, from the CDC guidelines, we don't know yet. We don't know yet. It should give you a little bit of security to know that I've already had it, and you know, I may be a little bit more resistant than the average person, but we don't know what that number is yet. And hopefully, as we get more data, and we still have a few more months before you have to go back to school, I'm hopeful they'll have a better answer to that. So the antibody test, if it comes back negative, you'll know you've never had COVID. So it may give you some information. The other problem that I didn't get a chance to talk about with the antibody test is it's a pretty complicated test and tends to have a significant amount of false positive. So there's a lot more nuance to, you just can't say all antibody tests are created equal. You have to dig into a little bit of which particular test might be best optimized for you, and your doctor can help you figure that out.
Great, thank you so much.
And now moving on to Jacob. Jacob, you had a question?
Hi, Corey. My questions were actually all answered. Thank you.
All right, you're good. Okay. Now moving on to Herbert. You had a question. Let's see if I can get him unmuted. Nope. Yeah, I'm trying to unmute him, but I can't. So unfortunately, we will have to move on to the next question. Jeff Kittner, ask your question.
Hi, Corey. Thanks very much. Doctor, this has been great. How does the spread of COVID-19 compare historically with other infectious diseases?
That is a great question. It's significantly more infectious. It spreads much more rapidly. You know, the example that I like to use is what happened in Seattle. So there was a choir that was having practice in Seattle, and this was prior to them going on lockdown. So there was nothing that happened here wrong. There were 52 choir members, and one of them had a cough. And they had about a 2 to 3 hour choir practice. And at the end of that choir practice, every single person got infected. So it's pretty contagious. And that's what makes COVID-19 so scary, that it doesn't take much to get infected. You compare it to like tuberculosis. Tuberculosis, it's actually surprisingly hard to get, but once you get it, it's surprisingly hard to treat. So we balance that out in terms of that. Ebola is also very infectious. The difference in Ebola is it tends to kill the host pretty rapidly. So it doesn't have the same spread that COVID has had. It is like the perfect balance of highly infectious, but a long disease process where people may not even know they have it, or they have mild symptoms and they're just spreading the virus.
That was a great question. Moving on, it looks like, Herbert, did you get unmuted?
Yes.
Awesome.
Do you hear me?
Yes.
Can you hear me?
Great.
Oh, okay. I'm sorry. Thank you so much, Dr. Bassett. I want to talk about vaccines. How many different vaccines are being looked at around the world, and how many tests have been done in any of these vaccines that are being created?
That is a great question, Herbert. And I'm not a vaccine person, as being a cardiologist and a informaticist, so I'm not the best person to ask this question to. But I will say almost every country is working on some type of vaccine development. Multiple pharmaceutical companies are working on it. I think, it goes to show that we have not cared for our vaccine development industry as well as we could have. And we could have had a more robust industry. Vaccines aren't reimbursed well. Development of vaccines aren't incentivized. So, but I'm optimistic. And Dr. Fauci from the NIH actually just had a press conference a couple of days ago that said, we will likely have, a couple of million doses of a vaccine come first quarter of next year. And if that is the case, I'm really optimistic for it. The advantage that we've had with COVID is after the SARS outbreak about 3 to 4 years ago, there were a lot of grants given out by the NIH for SARS vaccine development. And it just so happens that the SARS virus is very similar to the COVID virus because it's a SARS variant. And that has really accelerated the vaccine development process. So they're able to leverage all of the research that they did for the SARS virus and apply to the COVID virus to encourage it. The other part of it that I would say, and I moved to the slide just without knowing this question was coming, so it's like perfect, is I think the next frontier of medical advancement is going to be in the antivirals. I did not think that in my lifetime we would have a treatment that could eradicate a viral disease. And we've already seen one for hepatitis. That is transformative. And that really should me encouraged that the next frontier will be on antiviral therapies that will be almost as effective as our antibiotic therapies. So I'm really optimistic that the future will look bright for us.
Thank you so much, Dr. Bassett.
You're welcome. Thank you. That was a great question. Thank you.
And we have time for one more question. Just a reminder, if it didn't get to your question, please email us at publicaffairs@utsouthwestern.edu and we will get your questions answered. But our last question, Shirley, you had a question? Is Shirley is on? Okay. Well, I'm not sure if Shirley is still on, so I'm going to move to Jan, who had questions about the different strains.
I was wondering that there. Oh, am I on?
Yes,
yeah.
Go ahead.
I was wondering if these, you hear about these different strains of the virus, and it changed by the time it reached Europe, and that New York got the one from Europe. Do these different strains have different results, and would a vaccine cover all of them?
That's a great question, Jan. So the viruses, as they replicate, just like any cell that replicates, tends to accumulate mutations in its DNA, in its RNA in this case. And we monitor those changes to see how things evolve and migrate through space. And this is what we've seen. And when we do viral development, we look for parts of the virus that can't change effectively. And we target viral development to that. So we try to cover as many strains as possible. I don't know the specifics about the viral development, but when we traditionally do that, we try to target the part of the virus that doesn't change as much so that it is most effective over time. So parts of cells are conserved over time because they're important to the cell. And so if you can identify those parts, and that's why we have genome sequenced so many of these viruses to identify the parts that are conserved, and those are targets for both pharmaceutical drug therapy as well as vaccine development.
So Shirley actually did join us, so I'm gonna let her ask this very last question and then we'll go back to Jenny. So Shirley, do you wanna quickly ask a question?
Yes, I did want to ask the question. Immune therapy, is that one of the things that you're using to treat the patients that have COVID? I know we don't have a vaccine, I know we don't have, but is like enhancing a person's immune system, does that help with the treatment of COVID?
That's a great question, Shirley, and we do. So what we look for is we look for people who have had COVID, who've recovered from COVID, and have immunoglobulins in their circulatory system that can fight COVID. And we actually look for those people to volunteer to donate blood, and we can extract those immune globulins from them and give it to people who are severely ill, not just like your average person, but severely ill, to give them the best option for recovery. We tend to use it very infrequently because it does have some, it's not a free pass. It has some significant side effects because you're taking immune cells from immune complexes from somebody else and injecting it to someone, and that can cause all kinds of other autoimmune issues. So that's really done as a last resort. And we do that for not just COVID, but for all kinds of different diseases. We have treatments that do that, but those are usually from harvested tissues or from cell culture that are very precisely created. And those are the biologic agents that we're now seeing that are coming out for cancer therapies and rheumatological treatments as well that are really transforming those diseases.
Thank you. Thank you very much.
Well, Well, those were all great questions. I'm going to go ahead and pass it back to Jenny to finish us out for the evening.
Dr.
Thanks a lot, Corey.
Thank
you, Corey.
Thank you so much, Dr. Bassett and Shirley and all of our folks who asked questions tonight. I think we have more than an hour can take. So we have taken pictures of all the questions and we'll get back to you. But we want to thank you again for joining us tonight. We invite you back next week, 2 weeks from now, Thursday, June 25th, for the next program, The Magic of Sleep, the Real Fountain of Youth. I need to learn about that. And then everyone needs to. We also will do something about our COVID study on June 30th, and we'll be sending you information about that as well. As Dr. Bassett said, social distancing, physical distancing, wearing masks works. So please be safe when you're out there and help the folks in your sphere follow the rules, and let's flatten that curve. If you have any questions about COVID, visit us at utsouthwestern.edu/COVID-19. A lot of information on there. And of course, you can always look to the CDC or your local health department. Have a wonderful night. Thank you again so much for joining us. And we are calling it an evening.
Thank you, Jenny.
Thanks,
Thank you so much. Good night, everybody.
Thank you.
Thanks,
Thank
Dr.
you.